Welcome to the program. I'm your host, Neil Howard. Thank you for joining us. I'm going to have a conversation with Dr. Aswini Misro. He's from King's College in London, and he's joining us here on Health Professional Radio to talk about his project with a team consisting of some data scientists, software professionals, clinicians, and healthcare management professionals whose goal it is to build a cancer AI application that's free of charge to the community. Welcome to Health Professional Radio, Dr. Misro. How are you?
Yeah, I'm very well. Thank you for inviting.
Great. I'm glad that you could take the time with us. Now, I did say, of course, that you're from King's College in London. What is your background, and how is this team going to build this free AI for cancer patients?
So my background is I am a surgeon and an endoscopist. I'm a fellow of American College of Surgeons, which is one of the prestigious regulatory body. I am affiliated to all the top hospitals in London, including the King's College London, the Northwick Park and Hillingdon Hospital, which is another big hospital in London, and also to the St. Bart's NHS Trust. My area of special interest and expertise is clinical artificial intelligence. Our goal is to give the community the benefits of data science to the underserved or to the deprived, disconnected communities of the world. There has been a lot of high-tech and high-quality services which are available to people who are located in America and in Europe, but there are pockets in those in the Western Hemisphere, as well as many parts of the Africa and Asia and South America are still deprived of the quality cancer care. Therefore, all my team members, we have joined hands to make this affordable so that people can access this cancer artificial intelligence, which is meant to provide the standards of London cancer diagnosis and treatment to anyone, irrespective of their geographic location. So what we have done so far, we have tried and tested a few research applications based on artificial intelligence and clinical machine learning. We are quite encouraged by the results, and we are therefore planning to take it to the next stage where we will be releasing it for the public, where they can use it by using the web and mobile applications.
Now, are we talking cancer information? Are we talking about a network of information hubs for clinicians to better serve, or information for people who are seeking out these experts and their expertise, or is it a combination of the two? How is it going to work and connect?
So there is a big difference. When we talk about information, the age of information was 3 or 4 decades ago. Now, today's age is the age of intelligence. If I search on the Google that I have got a chest infection following a chemotherapy, I will find hundreds of search results pages, and I do not know which one of them is correct. According to our research, more than 50% of the sites results may be incomplete or inaccurate. And the person who has got a little bit of background knowledge, they do not know whether that information is applicable to them or not. So information is non-specific, does not have the actionable insight, and is not specific to a person. For example, just like a blood bag cross-matched for one person cannot be transfused to another person. Similarly, information is just not helpful and useful in a particular person's circumstances. And therefore, we have developed intelligence which is bespoke, specific, and it is actionable for that person's body, to the genetics. So in this application, what we are doing, we are collecting a person's all the data, including demographic data, including, of course, with consent, and with the genetic data, it's all the clinical information, radiological information, pathological information. So all the information will come to our AI hub where it will be processed. And once it is processed, the person will be left with a probable diagnosis. Of course, we can't be 100% sure, but with every single case going through, there is a rigorous monitoring in place to make sure that the patients are not left with a doubtful diagnosis or any wrong impression. And this is what is our main focus. And following the diagnosis, they will be given the treatments which are available, the experimental therapies, the research therapies, where are the nearest research centers. And if they want to speak to a clinician, by all means, they can speak by virtual consultation.
So are you saying that a person can just kind of log in, put in their data, and then the AI will diagnose them, recommend the treatment? After that, they are recommended to go seek out a specialist, right? They don't go and say, this is what I want to the specialist. The specialist then does his own testing. Is that correct?
The specialist may or may not do. Say, for example, if the tests have been done in the best qualified hospitals and the best qualified network, we have all the information with us, then there is no need to undergo treatment. So the why we decided to do this, I will tell you, is that when we compared the cancer outcomes of the people who are located in near the cancer centers, big cities and metropolitan cities, compare it with the people who are located in the countryside and rural areas, disconnected and remote peripheries, we found that 47% of the people, they have got delayed cancer diagnosis, and the delay can mean between 5 months to 14 months. And many of the people, they survived only few days following their diagnosis. Wow. And 28% of the people who are from the disconnected communities, they have a lower detection of cancer rate. So they were diagnosed, they were being treated provisionally as some medical conditions which are non-cancerous. And later on, they were found to have cancer. So to give the uniformity and the consistency of the evidence-based medicine to the rural community, we have to bridge this gap. And this we can only do by using the technologies. Mm-hmm. When we carried out a research, we found that, for example, Kenya, a significant high proportion of the patient have got access to a smartphone, but they don't have access to a quality cancer care. So how do we bridge this? Although it sounds like a paradox, but we have to use the technology which they have in their pocket to bridge this gap and to overcome the challenges.
If I'm understanding correctly, the goal of this AI project is to first offer fast and accurate as possible diagnosis to either a clinician or a potential patient, and then to bring that care to that disconnected community that has, as you say, access to a cell phone, but not to adequate care. Is that what's going to happen? Professionals will then be alerted and sent to certain locations that are underserved based on the AI's activity someplace else? Yes.
So say, for example, if a person has got he knows that he has got a proven cancer or symptoms suspicious of cancer, our AI will provide them the probable diagnosis and the treatment pathway, and will ask them that these are the clinicians who are in our network, but you are welcome to go to another clinician, and you can connect them to us. So our network will help you. And if you just are wanting a second review for your peace of mind, here you go. Here all the information are in front of you. So our aim is empowering the patient with information, giving them the specific clinical intelligence, and also liaising with their treating clinicians, to their doctors, their surgeons, to give them the treatments which they are not aware of.
Talk about how you plan to overcome or address the anxiety or the apprehension of some of these underserved communities to use this technology that they're unfamiliar with and may not trust.
Yes, we have spoken to a lot of charitable trusts who are working in that area. Yesterday, we had a meeting with one of the biggest trusts in that area. So these charitable trusts which work on non-for-profit, from their experience and the experience of their networks, we understand that people want it to be delivered in the language they speak and write. So this is one of our major feature. Second is that we want to empower a few people in the local area which will act as a local guardian for that community, so that if there is any issue, it can be sorted out locally instead of coming to us. So these are the two strategies we have for people's adoption to the new technologies. Actually, yesterday we had one director of a charity who had come, and he actually was giving example of an app called M-Pesa. So M-Pesa is an app which is there in the Kenya. Mm-hmm. So with that app, a person sitting at London will be able to send money to their mothers and fathers and relatives just in a matter of seconds, just using a mobile app.
Where can our listeners get some more information about this up-and-coming AI and more information about you as well, Dr. Misro, online?
Actually, my website is books.aswinimisro.uk. That is my website. In the website, it is still under construction because every day we are updating with new information, but all my research projects and everything is there. And also soon, as we are bringing the web applications and mobile applications, that will also be updated there.
Doctor, thank you so much for joining us here on Health Professional Radio. Quite informative. Hoping that we'll talk again soon.
Thank you. Thank you very much.
You've been listening to Health Professional Radio. I'm your host, Neil Howard. Transcripts and audio of this program are available at hpr.fm and healthprofessionalradio.com.au. You can subscribe to this podcast on iTunes, listen in and download at SoundCloud, and be sure and subscribe to our YouTube channel at Health Professional Radio at youtube.com. Thank you.